Hello, listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! All right, listeners, today we have a special technical development paper that was recently published in the journal that we'll be reviewing. The title of that paper is Denoised Ultra-Low-Dose Chest CT to Assess Pneumonia in Individuals Who Are Immunocompromised. This paper comes to us from our colleagues in Israel, and the lead author is Dr. Maximiliano Klug. Dr. Klug is here with us today to chat about the paper as well as the background and implication of results. Max, thank you so much for coming on to the podcast. Welcome.
Hi, Praveen. Thank you for having me. It's an honor to be here.
Of course, the pleasure is ours. Before we dive into the featured paper, let's learn a bit more about you. Max, where do you practice? What's your role at the place where you practice right now? And how did you get involved in this particular research?
Yes, well, I'm a radiologist at Shiva Medical Center in Israel. I'm getting ready also to start my fellowship in thoracic imaging and intervention at the MGH in Boston. And I started my journey in research actually when I was in med school in Santa Fe, Argentina. But this took off during my residency at Shiva. I was lucky to have amazing mentorship, especially from Dr. Edith Malone, which really pushed my research forward.
Fantastic. And Dr. Morom, as you had mentioned, is actually the senior author on the paper at hand. The Shiva Medical Center, for the audience that's not familiar with Israel, where in Israel is it?
Shiva Medical Center is located in Ramat Gan. It's located in central Israel, next to Tel Aviv, and it's the biggest hospital in Israel. It's one of the biggest hospitals in the Middle East. And currently, according to Newsweek, is one of the 10 top hospitals in the world. I think it's ranked 8. Yeah.
Awesome. And I think that the testament to that is this amongst many other papers and scientific studies that have been performed at Shiva Medical Center. Let's get into the paper at hand right now. Could you provide us some background as to why we care at all about ultra-low-dose chest CT and imaging in immunocompromised patients? The implication here is that ultra-low-dose chest CT provides a benefit over traditional CT imaging. So why do we need to explore alternative imaging techniques like ultra-low-dose chest CT?
Yeah, so Praveen, you know that for immunocompromised patient, lung infection can be extremely dangerous. These patients often need repeated chest CT scans to catch infections like invasive fungal pneumonia early, which can make a big difference in survival. But with frequent scans also come the concern about the radiation exposure. That's why techniques like ultra-low dose chest CT are so important. They drastically cut down the radiation dose.
Excellent. Okay, so your study mentions that ultra-low-dose chest CT has an increased inherent noise and therefore a decreased inherent diagnostic accuracy. Could you talk a little bit more about the challenges that this image noise presents and how it's hindered the widespread application of ultra-low-dose chest CT compared to traditional CT?
Yes, so the downside of lowering the dose is that it introduces more noise into the images. That noise can blur or obscure subtle signs of infections like nodules, granulous opacities, or trim pad patterns. This hinders the full clinical adoption of ultra-low dose techniques, and radiologists often feel uncertain when interpreting the scans, as they may feel that they are unable to confidently rule out an infection in certain cases. So this is what it is holding and hindering the widespread clinical application of ultra-low dose CT.
As we had mentioned in the title of the paper, we're talking not just about ultra-low dose, but denoised ultra-low dose chest CT. So I do want to get into how we do that denoising, but before we get there, how low is ultra-low dose, Max? Are we talking 50 times less, more than 50 times less radiation?
Yes. So the ultra-low dose CT scan in our study had a median effective dose radiation of just 0.12 millisieverts. That it's compared to 6.15 millisieverts for standard chest CT scan. Just for you to have an idea, even a low-dose CT is around 1.5 millisievert, which is roughly 15 chest X-rays. Ultra-low-dose CT brings this down to about 1.5 X-rays. So this is a major improvement in terms of patient safety. This is especially important for younger patients, those requiring frequent imaging, as cumulative radiation can increase the long-term risk of cancer. While minimizing radiation is crucial for preventing long-term complications, it's also equally important to maintain a diagnostic accuracy to ensure reliable clinical decision-making.
Okay, great. I think that's pretty impressive in terms of the degree of radiation dose reduction that you're achieving with your ultra-low dose chest CTs. We're saying 1.5 chest radiographs in terms of an equivalent radiation dose compared to 15 to 50 plus chest radiographs for a traditional chest CT. Wonderful. Let's now get into how the denoising was performed. As you've alluded to, ultra-low dose chest CT is inherently a noisier technique, but you used a relatively novel artificial intelligence-based algorithm to reduce the image noise. Could you dive into this a bit more and talk about what specific AI techniques were used?
Yes. So our lab trained an AI model to recognize and reduce the noise in ultra-low dose chest CT scan. We use a match scan pairs from a previous study, one ultra-low dose and the other the normal dose. Since they were taken during separate breath holds, we used a deformable registration tool called Elastics to line them up perfectly. Then we trained a convolutional neural network with 8 layers using techniques like batch normalization and an enhanced perceptual loss function. After 50 training epochs, the model was ready to denoise new scans, so we proceeded with the denoising of the evaluation set.
Understood. So sounds like there was a previous study which included both traditional CT scans and ultra-low dose chest CTs that were matched together through a elastics-based coupling, and then those were the base set of data to train this particular model. Is that correct?
Yes, that's correct.
Perfect.
And then we use a convolutional neural network that learn the images and learn how to denoise actually these ultra-low dose CT scans. And then we apply this AI algorithm that we train to denoise the evaluation set of the patients that we use for our study.
Okay, excellent. Let's now dive a little deeper into the methodology of the study in terms of the clinical question that was being asked. Your study evaluated the accuracy of standard ultra-low dose chest CTs, so we're talking not denoised ultra-low dose images, the denoised ultra-low dose chest CT images, and compared that to normal dose chest CT. And this was done for detecting pneumonia and a variety of other features of lung disease in the immunocompromised patients, for example, tree and bud patterns, septal thickening. Could you talk about what the major takeaways were, major key findings were in terms of the accuracy of those denoised ultra-low dose chest CT images?
So the denoising process improved the signals to noise ratio by 20%, which really helped to improve accuracy in the findings. It made a great difference in spotting things like ground glass opacities, micronodules, and even fine details like septal thickening and tree and bud patterns. But while it's not perfect, the denoised ultra-low dose chest CT images were much more reliable than the raw ones. So we, as radiologists, we felt better while interpreting these studies also as well.
Got it. So the denoised images were quite good, but not perfect compared to the traditional chest CT images in identifying the majority of pulmonary pathologies. Is that correct, Max?
We saw that the better detection across the board, also for fungal pneumonia, bacterial and viral pneumonia, for denoised ultra-low dose CT compared to raw ultra-low dose CT. The key here, again, was that the subtle inflammatory changes became easier to see after the noise was reduced.
Were there any specific types of either pathology or specific pneumonias that were more difficult to see with either ultra-low dose CT or denoise CT, or any particular examples of very challenging pulmonary pathology that was nearly indetectable by the standard ultra-low dose CT compared to the denoise CT?
So yes, as I say, some viral infection or fungal infection that have very subtle changes, ground glass opacity or twin bud patterns, due to the noise of the images in raw ultra-low dose CT, they were difficult to detect and we missed them. But the denoised ultra-low dose CT technology allow us to detect these subtle findings and improve the accuracy of the studies. Yeah.
Excellent. Okay, so I think we have a good handle as to what the key takeaways here were. Ultra low dose CT is possible in chest imaging. The denoising component substantially improves the accuracy compared to the out of the box ultra low dose chest CT images. And we're comparing this to the reference standard of traditional chest CT. Let's talk now about some of the limitations of the study. You had mentioned in the paper that this is a relatively small sample size of patients that was used. Could you describe perhaps any other limitations or how future studies may help mitigate some of these limitations?
Yes, so the biggest limitation here was our sample size. It was a very small one, 55 patients, I think, if I recall correctly. But yeah, this was a proof of concept study. So in order to validate it, we need larger multi-center trials. And I believe that the next step is applying this denoising algorithm across different hospitals and patient populations in order to see how well it generalizes.
In your personal opinion, Max, the traditional not denoised ultra low dose CT images are achievable with really a variety of different types of equipment. Do you think that that is ready to be deployed in clinical prime time, or is the denoising really needed to make clinical decisions for these patients? Your personal opinion.
Well, my personal opinion is that this is a new technology that need to be tested across different hospitals, different machines. But it's promising for this patient, especially for the young population, because this reduces significantly the radiation. Um, for example, some ultra low dose CT studies can find they will identify pneumonia, consolidation, and some findings that are more prominent. But the problem here is that when you have very subtle findings of pneumonia, ground glass, or twin bud pattern that can be missed with due to the noise of the imaging, here you need some kind of tool that helps you with this. And the AI and denoising technology can prove to be a game changer in the future for this population and for clinical detection of pneumonia.
Yeah, Max, I think you've outlined kind of exactly what we need to do to validate these denoising techniques in the future. Let's fast forward to that future, a setting in which we have adequately validated this denoised ultra low dose chest CT. Where do you envision this technology playing a role in decision making for patients across the world, immunocompromised or not?
Yeah, so I think this technology has great potential, especially for the immunocompromised patients. I think this technology will allow clinicians to screen more confidently and frequently without worrying about radiation risks, especially in the young population. And I feel that the radiology will feel more confident interpreting these denoise scans compared to the raw ultra-low dose CT scans. And this will improve communication and ultimately patient care.
You mentioned in the discussion of the paper applications even beyond immunocompromised populations, for example, serial restaging in patients with oncologic diseases, lung cancer screening programs across the world. Could you talk to us a bit more about these potential applications outside of our immunocompromised patients?
Okay, so we had a previous study that we evaluated this algorithm in the detection of coronary artery calcium scoring, which helps assess cardiovascular risk. We published this in another journal in clinical radiology. This is also particularly relevant for immunocompromised patients too, so because this can prove a tool to screen for coronary artery calcium, also assess cardiovascular risk, and this can guide treatment decisions like whether or not to start statins. You know, if you have a considerant high AGAN score, you will need to start a statin treatment. But so this algorithm can help as a tool for screening the patients with the cardiovascular risk as well.
Fantastic. So we're looking at applications beyond just pulmonary medicine, but also cardiovascular medicine for this type of denoised ultra-low dose chest CT. I want to start coming to the conclusion of our conversation and ask, what would you like to convey to the radiologists and our non-radiology clinical colleagues out there about what the potential benefits and implication of this type of denoised ultra-low dose CT technique is for clinical medicine?
Yeah, so I believe that the key takeaway is that with the system of AI, we are advancing towards safer imaging with significantly reduced radiation exposure, all while maintaining diagnostic accuracy. I feel that only time will tell if the noise ultra-low dose chest CT will become a standardized tool for early detection of pneumonia in immunocompromised patients. But I'm optimistic that this will be the situation, and I feel that it will prove to be a great tool for this population and young populations screening for pneumonia, early signs of pneumonia.
After having read the paper and really seen the images that you put into this paper, I was very enthusiastic to the point where I wanted to go to my local hospital that I work at and bring down all of the tube currents on all of my scans and see how good I can get the pictures, because it was really impressive to see the ability to detect pathology not only on the denoised images, but even just the ultra-low dose CT images that are not denoised. Super impressive work, and thank you very much for the publication into the journal and the contribution to the science. As we come now to the close of the conversation, Max, do you have any final thoughts for our listeners?
Just I encourage everyone to keep doing research, also researching this topic. I think it's very important to keep it in the loop, because we have a lot of patients who are young and who are immunocompromised, and they deserve that we give our best and try to reduce radiation while maintaining diagnostic accuracy. And I want to thank also my mentor and the head of our AI lab, Arnaldo Mayer, and Dr. Edith Maron, who helped me with this study. Thank you very much, Praveen, for this opportunity. It was very nice to speak with you.
Of course, Max, thank you again for your time and your dedication. Really, really appreciate it from me personally, as well as the entire cardiothoracic science community. For our listeners out there, if you like what you hear from Dr. Klug and colleagues like Dr. Klug, please rate, review, and subscribe to the podcast. That helps others out there find content like this. Super appreciative to you, Dr. Klug, to your team, as well as everyone that's contributing to the cardiothoracic radiology science. Once again, this is the Radiology Cardiothoracic Imaging Journal podcast. We will see you next time.